So, Dr. Ahmed, you are leaning to the innovation and how we do it, the innovation in healthcare, the innovation in payment, the innovation in engaging the population and the stakeholders. That will take us to the next question, Hussein. What are some of the innovation that CCHI or the industry is considering to help us move or accelerate how fast we can move?
Yeah, I mean, it's always a marathon rather than a sprint when you do national transformation. This is my fourth and fifth, and I think the aim is always to get all together at the finish line. This is the success story. So before answering to you, Dr. Hadi, just one small observation. I think we managed today to achieve a major objective, and that is to debunk the myth that population health is a public health issue. It's only public health system. Wrong. We are all in charge of the health system, and one way or another it's our duty to improve the health status, whether that's a payer, provider, regulator, healthcare professional, or even the third sector and NGOs. However, when it comes to innovation, payers have really a critical role, and I think it's about time that payers move on from the traditional outdated model of managing claims or managing risk through claims management and move into managing the health of individuals. Moving from their outdated business-to-business model of an end user where they consider contracts, how many lives I have insured, to an individual end user and a more personalized care. And to be honest, thanks to the leadership of Dr. Shabab and this great team, I'm seeing a big creative destruction coming on its way, coupled with health consumer revolution, where this information asymmetry will be even further reduced. So, and we, as regulators, CCHI, we are here to enable that. Now, back to your question, definitely population health 5x5 is just one piece in the mosaic of the value-based healthcare or the transformation. We require some prerequisites, or I better call them enablers, and we mentioned most of them, but I just focus only on three. First is data, information and knowledge. We mentioned NAFIs, we mentioned registries. Without data, information and knowledge, we cannot segment the population, as Lamar said. We cannot understand what their need is, what they're suffering from. And it's not only NAFIs that will help. We need to further enrich the data with additional information, registries, surveys, patient-reported outcomes, and experience measures, so on and so forth, so we can better understand the needs. The second is innovative care models. We talked a lot about that. We talked about the new model of primary care. I think we need to change the way how we deliver care in order to make justice to population health. Otherwise, if we have diagnosed what's wrong with our population, but we don't have the solution, then we haven't done a lot. Last but not least is how all of this gets aligned, and how do you create incentives, financial ways. And this is where the innovative payment models should come. And this is something also we are working on, and probably very soon we will come up with a white paper as well on how we see that the payment needs to be restructured and reformed as part of the CCHI overall transformation. So watch that space, please. Yeah.
I would really like to hear from the, to the mic. Shukran. Can you introduce yourself, please, and the question?
Good morning, all. This is Malik Al-Musa, CEO for Musa Hospital. I have two questions, one for CCHI and one for Lamar. Sure.
Yeah, it's good.
So the first question is for CCHI. It's a great initiatives and great programs, but have you considered piloting certain payment mechanism for us with the certain providers, with the certain insurance companies that they can do for a specific target populations, for example, diabetes, for example. So everyone is scared now, how I'm getting paid. The insurance companies is really hesitant to do it because no one really knows what will happen over the course of the coming 1 year or 2 years. So instead of, going all feet in ground and then rolling back the whole program, why not to pilot it in a certain organization with a certain mature insurance companies, and then we see it. The other question is for Lamar about we are now almost 12 years post Affordable Care Act. So this was Obamacare, was the aim, was value-based healthcare, transforming the care. What's the major transformation that you saw, the outcomes of that transformation? Well, I know that some certain states did not roll into the program, but what's the things that you see it's really did a major change to the whole health system for outcomes or cost of living?
So great two questions. Thank you very much. Hussein, I will direct that to you. So instead of going full speed, why not pick a disease, diabetes, let's say, a provider and an insurance company, and let's see how it goes with them?
Yeah, very good question, and timing is very critical. We are cognizant of the need to make changes in the way how services are funded and reimbursed. However, we don't want to put the cart before the horse. I think first we need to start with population health aspects, identify those KPIs, change the model of care that is currently, then introduce innovative payment models that are means to an end rather than an end itself. So it's just an instrument to incentivize the right, proper care to achieve best outcomes at lower cost. So we're thinking about that. And there are ideas, especially around diabetes, how to introduce some sort of pay-for-performance model where we will, the payers will measure the performance, and we mentioned some examples, HbA1c, controlling the glucose levels, other complications coming from microvascular or ocular. So there are ways, there are mechanisms. We are working around how to design, but I think we need to do the first steps to define what is the care model that we want to introduce, what are the areas that we want to address, and then the innovative payment models will need to follow suit.
Okay, so it's on the same track? Yes. Please go ahead.
And I do work for CCHI, even though Dr. Shabab is partly my boss, because I'm a consultant to the CCHI. But I would like to share a successful experiment that we did with the CCHI to show the impact of something like diabetes. We did using claims data of the 3 major insurance companies. We got it from the CCHI database, and we looked at the cardiovascular / cerebrovascular complications of diabetes of those insured patients before and after they were diagnosed with diabetes. And we looked even at multiple costs, including renal failure, cardiovascular coronary artery disease, PCI, ER visits, everything. And we calculated the cost based on the claims data. I think this is a very important message that needs to go to the insurance company and tell them, listen guys, those are the uncontrolled diabetics over the last 5 years, before they were diagnosed and after they were diagnosed with any cardiovascular or macrovascular, I would say, complication. Look at the cost, the huge surge in the cost after they were diagnosed with the first macrovascular complication. It's huge impact on you as an insurer. It's a huge impact on the quality of life of the patient, on the overall healthcare system. We have the data, we're publishing it soon. So I think starting with showing them the numbers, showing them the facts and feeling the impact, then they thinking toward prevention, maximizing HbA1c target goals, preventing complications of diabetes before they happen, because it actually reduces the overall cost of insurance companies. And hopefully this will be published soon and will be shared with everybody.
Thank you very much, Dr. Shabab.
Thank you, Abdul Latif. I think it is always smart to start growth, and I agree with you 100%. We need to pilot some of those initiatives. However, I agree with Hussein also. We have to have the canvas where we are writing what we are targeting. And two different qualities. And then define a very structured pilot that we can test and measure. And I think to prepare for that, we launched at the beginning of the year the unified contracts between the payer and the provider. That is kind of building the infrastructure between the engagement between the payer and the provider, where we define the standard codes and the standards of service codes that introduced by the provider. So we can then track and measure and then incentivize. So I think by adopting, we gave the market 12 months to adopt to the new unified contracts. It's not only term and condition, it's also what it requires from coding standard and revenue cycle management, and also minimum data sets that you need to submit. So I think by achieving that, we will put the first cornerstone when moving toward your suggestion. And I do believe they did something in Ministry of Health in a small scale where they bundle several pay. I think they did it 2 or 3 years ago. So I think we will adopt some of those examples, and definitely we need the payer to take the lead and maybe yes, I forgot, you're on the payer side now. So I think they need to take the lead and to design a certain payment mechanism, take the initiative, strike the agreement with the provider, and we'll be supportive to that.
Thank you very much. I will go to one of the players, but I want to hear the answer to the question raised. Affordable Care Act, 12 years, what did you achieve?
Yes, thank you. So the Obamacare transformation, as you mentioned, has been a dozen years or so in the making. There's been a lot of successes. Obviously, the U.S. healthcare system is huge, $4 trillion, I think, or so, or almost 20% of the GDP. Very fragmented, a lot of capacity, a lot of chaos. Okay, so 2 things the Obamacare policy did. One is it made the law. So when you talk about carrots and sticks, the law is really the stick. Everybody's got to get on board, and we started by establishing the essential health benefits, which is equivalent to the essential benefit package here. So what's the floor that everybody should get by law? And then the carrots, which are really the payment transformation that we're talking about. So when you allow the innovation of payers to start recognizing and rewarding advanced care systems, those folks who might be an accredited, let's say, patient-centered medical home, they're doing integrated, coordinated care, and when you move to a quality payment program, which was another real success story, which is basically stating that everybody has to meet a certain quality. If you exceed that quality, you get a bonus. This is the carrot. If you go below it, you get penalized, money gets taken away, there's the stick again. And so it really is about having the law, the policy, people, that's our role, CCHI, and then the payers being innovative and saying, you know what, we're going to give you a partially capitated payment for all your diabetics. Okay, we're going to pay you up front, proactively. Now you manage within that amount of money, and if you do better than the expected standard, we'll let you share in that savings, and we'll give you that. So it happens to be the way you pay folks is the way they behave, and the way you penalize folks helps to get them behaving in the right way. So we're talking about transforming the health behavior of all the entities in the sector. So a lot of good lessons, and we've met with NCQA. They do the HEDIS measures, they do accreditation of patient-centered medical home, the accreditation of population health accreditation, and so we're actually engaged with them, and we hope to have some train-the-trainer sessions with them that we can then share with the sector going forward.
Thank you very much. Dr. Ayman, I heard the word payer more than 100 times so far. We need to hear from you.
صباح الخير. أيمن السليماني, Medical Director of Bupa Arabia. Very happy to be here and part of the discussion, lovely discussion, and a topic that I would consider it as a very close topic to my heart, value-based healthcare. A few points probably I just need to highlight. Our experience within Bupa Arabia and into the adventure of going into value-based healthcare. What are the challenges that we came across, and I think if we need to share it over here, it would be helpful to help the whole sector to improve going forward. So it's, again, going quality over cost, right? It's value. So that's one important part. When we're talking about value-based healthcare, we're not talking about cutting costs. And that's the impression that goes directly when the payers start talking, that they're trying to reduce costs. This is not what we're talking about. This is not what we venture within Bupa Arabia. What we are trying to do is to improve the quality of the care that's being delivered at the start, if we stay at the same cost, and still that would be a benefit to us. So it's not a cost-cutting exercise. So that's point number one, and that's something that I can tell you for sure, coming from the private insurance company, that's what we're thinking. Now, have we tried to pilot this? Yes, we did. We identified a group of the population with a certain client who is interested in the health of their beneficiaries. We've identified the disease, and we've identified the algorithm, how can you move this forward? And we've tried this with diabetes. Now, rather than telling you the success stories, I will tell you what are the challenges so we can learn from. One of the major challenges, what Professor Ahmed have talked about, what's in it for the different stakeholders. So one stakeholder would be the provider. That's not an exercise that could be done single-handed from the payer alone. That has to be some kind of harmony between the payer and the provider to be able to achieve what we're looking for. Till now, we are facing some difficulties in passing this on with some kind of a trust issue that's being built between the two sides. And that's something that's not a secret to everyone. How can we move it forward? How can we improve that relationship? And we are working on that exercise to improve it and put a very good model that people will start to adopt and move it forward. The other issue is the beneficiaries themselves. I'll give you an example. On average, we've seen the diabetic patients, they go to the provider on a yearly basis almost 12 times per year. Some of the diabetics, as you know, probably they don't need to go that frequently. Now, if I go and tell the patient, you need to go only 2 times, maximum of 4 times a year, there is a kind of discrepancy between what I tell him as a payer and what the provider will be telling him. At the end of the day, what I end up doing, I've developed the program, they get enrolled into the program, they go 2 or 4 times a year, sometimes even 1 time if they're well controlled, but unfortunately they continue to do the same journey as they used to do. That's an extra cost, that's a waste. How can we take that away? And I think that there might be some kind of it's either using the stick or the carrot, and I think there is some kind of incentive that we can incentivize our beneficiaries in trying to adopt those programs and not going into the traditional way of going to the hospital every month to dispense their medications. So that's one issue. The payer, if I start telling him I'm getting you less patients per year, that's a loss of revenue to the provider. And that's an issue that we need to address. How can we make sure that we're not fighting on the same dollar? Because if I get the patient to go less times to the hospital, that's less revenue to the provider. And we need to make sure that we have some kind of a mechanism that will ensure that we'll increase the revenue by having more patients. Now, the good example that we've done with the diabetes program, we selected our population, as probably most of you know better than I do. A normal population will give you a distribution of the diabetic population, 60% to be well controlled. Unfortunately, our pilot, there were only 25% of our patients were controlled. By just putting them into a program, even though that they continue to do their usual routine follow-ups, we improved this from 25 to 40%. So that was a huge success to us, that we improved the population that probably won't get the benefit of the commercial benefit on that on the short term, but we will gain it on the long term. Sustainability of that program, how can we push it further? How can we advertise for such programs? I think that's an important tool that we need to put on the table at this point of time, and then trying to find the issues that we put are sort of hurdles to the program. We love to have this to move forward. The maturity within the sector is extremely important, and that's what we're looking for. We're looking for all the support that we can got from all the stakeholders, whether it's the regulators, whether it's the providers, and we really hand in hand. We're hoping that we can move this forward. Thank you very much.
Thank you very much. Very interesting. Thank you for sharing. So we have, if I want to summarize it, it's trust, sustainability, and long term. And this is what we are trying through this venue to achieve. How can we come up to that relation that's where is trust, sustainable, and is long term? Now, in order to ensure that even if we want to go fast and accelerated, we have to be safe, and we can only do that through set of standard and the qualification. Dr. Hussam, can you share with us your view on the qualification and standard in ensuring that we are on the right path?
Yes, and wonderful actually discussion. I'm really happy to be part of it. When Dr. Ayman mentioned the issue of not being alone doing the journey towards the population health, it actually just drew my attention to many issues related to the standards. I've been in the healthcare for over 40 years, and some of my interns actually are now great leaders in healthcare in the kingdom. And the usual question I always get is, Hussam, stop giving us more standards. We do not want to work. And my answer is very simple, by the way. We're using the standards in the wrong way. We're using it for an exam that happens once in a while, maybe yearly, maybe every 3 years, which is not the right thing. The standards should be utilized as a management book. So this is something that you wake up and do every day. It's part of your routine. And that's why actually writing the standards need to be in a very particular way that is towards implementation rather than just compliance. So our standards actually are going into the payer side. We don't have any standards regulating the payers as such. We have lots of standards on the provider side, for example, the mandatory from Sebahi and the other voluntary like the Joint Commission or others. And if you take the provider side, for example, Sebahi is only looking at the quality, mainly focusing on structures and processes with the outcomes as well. We're modifying the standards to have more enforcement on outcomes, but we're missing the part that relates to the economics. We're missing the part that relates to the insurance. We're missing the part that ensures the beneficiaries are on the top, the aim. Their experience is what really what really matters to us, and that's why we're bridging this gap with the current standards from Sebahi, insisting on how to get the right revenue cycle management, to get the right outcomes from it, insisting as well on the changes towards the value-based healthcare, the innovative products, insisting on the beneficiaries' rights, insisting on population health. So population health is a big issue actually that we need to move forward with. Again, the backbone, which is the digitalization, we have a special chapter to ensure that data is really managed the way it should be. If you look at the current status and if you look at actual research, what is the extent of data governance in Kingdom of Saudi Arabia? There's a huge research actually that took over 25 different industries in the kingdom. One of them was healthcare, and only 5 hospitals were concerned or have a formal data governance framework. And that's really very annoying, and we will never move unless we really know how to manage our data, and without a data governance framework we will not be able actually to move forward. So we're insisting on the data governance, we're insisting on how you manage your data, and we're insisting on a proactive and a reactive process when you lose your data tools. So we're talking again about the business continuity plans. It's a very dedicated chapter, very well focused, and it's your day-to-day activity. Now, moving to the payer side, knowing that there are no regulatory standards as such, we had to go through the initial structures and processes, including the governance, including leadership, including the right structure that we feel, and that's actually internationally recognized, that you need to do your business. So having a medical director, having a medical team, qualifications, the consultants backup, and so on and so forth is very important. The payers program is a bit an extension rather than what's happening in the providers. So beneficiaries' rights is on top of the list. Population health And what we've explained actually in the population health is added innovation. And it's not a one-man show, as Dr. Ayman just mentioned. We insisted that the payers should actually cooperate with the providers, or in the terms of Dr. Ayman, providers need to cooperate with the payers. And there should be some way of ensuring that we're actually getting paid for performance rather than getting paid for the service. And that's why we're moving towards the quality of the services being captured by the payers, the prems and the proms, the experience and the outcomes are extremely important as well. And in both programs, finally, we get up a very nice balanced scorecard. The balanced scorecard is going to be helpful not only to test your own organization, but also is going to be the future for the pay for performance. What we managed to do in our standards for the payers is to stay away from any financials, because we're fully aware that this is something related to the central bank. But we have not ignored other sustainability factors like the human resource, for example, how you build up your human resource, how you keep them motivated, innovated, and at the same time upgraded in their career ladder, and so on and so forth. So finally, if you look at the objectives of the both programs, number one, we're getting the better health for our population. Number two, we're very transparent because we're capturing indicators from both sides, and we know how the market actually is now or is going to be performing. Number three, all the brokers, the employers will have actually a very clear understanding of how both the payers and providers are actually interacting and working in the market. So it's a great opportunity for all of us really to follow. Now, having said that, I'm going back again to insist that it's a management book. It's not something really that is added. It's not a burden. And in order to ensure that it's not going to be a burden financially on the organizations, we managed, as Dr. Lamar actually showed in one of his slides, to move it along with the 5x5 program. So there is a mandatory standards that we have to follow in year one, which are really the basics. And we gradually upscale the requirements. And hopefully after the 5 years, we could actually start thinking about actually the new economy of our healthcare, that we're really following value-based healthcare and better care with less quality and pay for performance.
Thank you very much, Dr. Hussam. So it's basically it's a management guide to our journey to the value-based healthcare. Dr. Rana, Peter Drucker, the godfather of the leadership and management, quote famous that a small healthcare organization is maybe the most complex to manage among all industry. And we are today at the stage of transforming the whole healthcare system. We're not talking about a single identity. How can we make sure the transformation is aligned and we are not working in silo, the private, the government, the different initiative? How can we make sure that we synergize rather than work in silos?
Thank you for that, Dr. Hadi. I think to give a comprehensive answer, I need to start from the back and move forward. So transformation in the healthcare sector in Saudi Arabia actually didn't start today. It started more than 6 years ago. And it started in the Ministry of Health particularly, because they came to the realization that there was unavoidable conflict of interest that was happening, in the sense that the ministry was really creating 3 roles. The ministry was the regulator, was the provider, and was the payer, all 3 in one. With that realization, it was decided that those 3 roles really have to disintegrate. The role of the regulator will remain with the ministry because that's the rightful place where it should happen, but it needs to expand beyond just the facilities and the assets of the Ministry of Health and the private sector as it is, but to the entire ecosystem. So one challenge is, how does the ministry grow and develop into this new regulator role, this uncharted territory of a super regulator, a real regulator of the sector? And then, as we all know, the provider side moves towards these regional-based clusters in which issues of population health management become imperative, because that is a true opportunity where you say, I am responsible for a defined set of demographic population. I need to understand what their issues are, who are the most needy of those population, what environmental factors really come into play, what sort of social determinants of health take place in that particular geographic distribution. So the plan is to move forward with that. There are more and more clusters coming online, as we know, so that's on the provider side. And on the payer side, it's moving towards what is now the Program for Health Assurance and Purchasing, which ultimately will be NCHI, the National Center for Health Insurance. So that's with the ministry, separating those three roles. Then what central government realized is that the transformation that's happening at the Ministry of Health need not be only pertinent to the Ministry of Health. It needs to expand to the entire sector, to the entire ecosystem. So fast forward to late 2020, and that's when the Health Sector Transformation Program, or HSTP, was created. HSTP is the newest VRP, or Vision Realization Program, under Vision 2030. We all know that there are a number of vision programs. I believe there are 13 in total as we speak. But to talk about the Health Sector Transformation Program, it really is the vehicle in which we all, as stakeholders in the sector, need to collaborate on creating this new canvas that we have in which we will operate not only for this generation, but for generations to come. And having said that, I'm reminded by one of our mentors in the program, Dr. Saadi Tahir. Many of you know, he's always reminding us that healthcare is a complex, adaptive system. And what that means is that we would be very unwise to think that we can fix a part of it and that part will impact the whole. We really have to have a holistic view on all of different players. There are many different moving parts. It's mind-blowing to even think about how many moving parts come into play when it comes to healthcare. But I'll be happy to share with you the following. We're now in the beginning phases of the strategy architecture. And when we say strategy architecture, it's the sector-wide strategy. And realizing that healthcare is a complex adaptive system, we said there are a number of pillars that we need to really look into. So today we have 11 pillars, and I will tell you that they're growing, and they're growing at a mind-blowing speed. But one of the pillars is preventive care, public health, and health security. And that comes from the realization that if we don't put all of these wonderful minds together and say, how can we deal with public health, not only as a government tool, but also as a cross-ministerial program? There's one of the initiatives that really speaks to that, which is the Health in All Policies, which is one spin-off out of the HSTP, which is basically a cross-ministerial coordination body that looks at public health initiatives, looks at policy creation that is cross-ministerial. Things like a sugar tax, things like a tobacco tax, nudging the population towards healthy lifestyle and healthy living. That is not only the burden of us as healthcare providers, that is the burden of society, and that's the burden of government. So looking at that. In addition, mind-opening statistics that as we are diving into detailing our strategy, is that for every dollar spent on preventive care and public health, there's a $6.5 that you get in return. Some of it is immediate return, and some takes obviously 5-10 years to come into fruition. But on issues like mental health, the return on investment is within a year. And that's what's really remarkable. So definitely looking at the different enablers of transformation and the different pillars that will really guide us on how the strategy of the sector will move forward. Governance, for example, we're looking at governance and regulation. So how will the Ministry of Health operate in this new ecosystem or in this new space as a super regulator and really take claim of that space for the first time for all providers? What are the tools that it needs? What kind of instruments in terms of policy creation, the carrot and the stick that Lamar talked about, are issues that we are debating and struggling with now. Integrated care is one of the pillars of the strategy, and within integrated care, there are many sort of sub-pillars, but one of them is the new model of care, which was mentioned by many of our esteemed panelists this morning. How will the new model of care move us forward in a cohesive way for better population for our health? We were struck to know that when we did the benchmark exercise and compared where we are in the Kingdom of Saudi Arabia with leading countries such as the UK, Canada, Singapore, Sweden, in those countries, 70 to 90% of healthcare is provided in the primary healthcare setting. It's shocking. 70 to 90% of healthcare is provided in the primary healthcare setting. So things like screening, education, immunization, procedures, gateway creation happens at the primary healthcare setting. And in the Kingdom of Saudi Arabia, we really at this stage need to invert the pyramid. We need to invert the pyramid on its head. So we all know, because we live and work in healthcare, healthcare in Saudi Arabia over many, many decades was really built around hospitals. We built hospitals, we equipped these hospitals, and we said to patients, if you're sick, if you're tired, come to the hospitals. What we're now realizing is that the solution for transformation is not building more hospitals, is not adding more beds, but it's shifting that pyramid on its head and saying, how can we restore the trust of our people and our communities in primary healthcare? How can we restore the trust of our people in their family physicians? And we're always reminded, patients vote with their feet, right? So if they believe that they're gonna get the care that they want in a trusted, safe environment, in a primary healthcare setting, they will come. But unless we do that, we will continue to clog our emergency departments with patients that come in for headaches and tummy aches, clogging our very expensive emergency care departments instead of going to their trusted family physician. And it's realizing that if we don't do all of this today, the costs of healthcare are going to be monumental. I'll share a figure with you, and this is around public cost of healthcare costs or healthcare expenditures in 2019, and this is public, not including private. It came to a combined annual spend of 123 billion riyals, right? This is in 2019, and the projections say that if we do nothing, that number is going to mushroom to 249 billion riyals in 2030. And I can tell you from discussions that we've had with the Ministry of Finance, they say, when we present this to them, don't even show us this number. We can't afford it. So if we don't do something today to ensure that we're tilting that pyramid on its head, it will be too late. But I'm sure that with the people such as CCHI as our trusted partners and many others in this room, I think we can do what our generations to come need, inshallah, in 2030.
Thank you very much. So you mentioned very important points: preventive medicine, mental health, primary care, and it's complex. But what the message I get, at least me personally, transformation is not an option. Status quo is not an option. Things has to move, and transformation is a train. It might have stop station, you can ride on, but the train is moving. It's moving. We are trying to accelerate the movement of the train. Can you post the next question, please? So it's 1 minute break. It'll be like a long day for you. So we're gonna throw a puzzle question to you, and those who solve the puzzle will be another winner for the day, in addition to the early morning question. Can we have the question, please, Nada? And this puzzle was created by a group of pharmacists. Though the pharmacists, They are the only people who can read the handwritten of a physician. They give us the hardest time because they know we're going to come back to them for anything that we prescribe. So the question is, can you have it, Nada? What is IDF? What are the most important benefits of insurance drug formulary? The one controlling the stage is a pharmacist, so please make sure you correctly answer her question. Dr. Ahmed, before we go to answering the question, what is this IDF?
Okay, great. So IDF stands for Insurance Drug Formulary. And in order to explain it, let's explain first what a formulary is. Everybody knows drug or insurance, but formulary is usually a list of medications for a particular healthcare system that contains the prescribing information about the medication, the guidelines, the therapeutic guidelines, the restrictions, the indications, and other drug information about that particular medication. And there are two different types of formularies. There's what we call a closed formulary system, and this is usually a concept that is adopted by governmental healthcare systems or publicly funded healthcare systems outside the kingdom. The meaning of closed formulary system is that that particular healthcare system, let's say a hospital, decides to select certain medications that the prescriber should only prescribe from that particular list. And they cannot prescribe outside that particular list except through a process of what we call non-drug formulary process. The open formulary system is what's usually practiced in the United States mainly because it's based on healthcare insurance system mainly, excluding VA, military, and other publicly funded hospitals. But most of the healthcare system in the United States is based on insurance, which means that the prescriber and the patient can select any of the approved medications in the market, as long as it's covered by the insurance policy. So you will find in hospitals in the United States, for example, that have an open formulary system, you could find 7-8 different statins in their formulary, 10 ACE inhibitors, and so on. While on the closed formulary system, you will find 2 statins, 2 ACE or 3 ACE inhibitors, and 2 ARBs, and so on. So the concept is a little bit different, but the main idea is the same. Now, Insurance Drug Formulary is an initiative by the CCHI to help govern the practice and ensures the equity of healthcare provided to the patient who are under insurance policies here in Saudi Arabia. Let me go back to the 3 pillars that Dr. Shabab talked about. 1, improve access to care. 2nd, improve the quality of care. And 3rd, value-based, or providing the care with the lowest possible or the most cost-effective approach. And the IDF is actually a testimony of these 3 pillars. We want to improve the care by providing the patient what they deserve in terms of coverage, so that if we have a medication that has been proven to improve quality of of care, reduce morbidity, reduce mortality, that this patient is not denied the medication by the insurance company. At the same time, we would like to make sure that the providers would adhere to the best evidence-based practice by incorporating an insurance drug formulary that contains two components. One, evidence-based guidelines for the use of these medications, and evidence-based indications. And it's very important to control and govern the practice of the providers as well as the practice of the insurers. The ultimate goal is improve patient access to best available medications. Number two, improve the equity so that the patient, the diabetic patient who is prescribed an SGLT2 inhibitor, for example, to prevent heart failure and coronary artery disease in the future, let's say 5 years from now, has the same equitable chance of another diabetic patient who is insured by another insurance company and maybe cared for by another provider. The second thing is we wanted also to adopt a stepwise approach for managing these diseases because we don't want the provider, for example, to jump to the most expensive medications without starting the cheaper alternatives that have been proven to improve quality of care, decrease morbidity and mortality. So it's actually a balance. It's a very delicate balance between providing the best available treatment options to the patients, at the same time maintaining the overall healthcare cost. As we heard from Lamar, 21.7% of the overall claims in terms of cost come from medications. So there is also an added benefit with the establishment of the insurance drug formulary of controlling the overall healthcare cost, so that insurers can actually build a case where they can expand the insurance policy to cover other aspects of healthcare by reducing the overall, I would say, spending on medications. So the insurance drug formulary was an initiative that was started about 2 years ago by the CCHI. The goal is to improve equitable care, provide the best available evidence-based guidelines for managing certain diseases with the medications, as well as improve the access of the patient. This has been already completed. And several months ago, it will be linked to the essential benefit package, because part of the essential benefit package is providing access to these medications, as well as this is actually a living document, so it really needs to be updated continuously. And now we have the infrastructure and the governance system where we have a governance formulary governing committee, and then we have a formulary and therapeutics committee that reviews newer medications, newer indications, newer guidelines in order to update that living document. In my opinion, and I will go back to what Dr. Ibrahim mentioned before, we really need to implement and then come back in 6 to 12 months and evaluate what the impact of our new initiative. In my opinion, this is going to improve the care to the patient, improve their access, reduce the cost, the overall cost on the insurance and providers, and make sure that the patient actually gets what he or she deserves. Lastly, the insurance drug formulary is going to be linked, hopefully, with our electronic national electronic health system, where patients, we could actually reflect these recommendations in terms of stepwise approach for selecting medications electronically. Hopefully in the future, it could be linked to a national computerized prescriber order entry, where this actually can be used as a vehicle for introducing the IDF to the community.
Thank you.
That's all I have about it.
I will go to Dr. Ibrahim. Make it simple for me. What practically IDF will mean for me as payer, as a provider, and a patient? If you launch it, how I'm going to be impacted as any of the three?
Think simple about medication. But I mean, I will not, re-emphasize the importance of introducing the idea to the market. It's formulary. It's not just a document that you introduce or a list that people need to follow up, or a payer need to pay, or a provider need to stick to. It's changing how access to medicine is happening in the market. How patients are getting their medication. They actually are assessing their spending, assessing what product need to be included, assessing where the pocket of high costs need to be improved, assessing how actually like every day or every week need to revise and see exactly what area of improvement that you need to adapt to. An area where probably a lot of payer in the market is not yet familiarized with is pharmacy benefit management, or PBM. Pharmacy benefit management is an essential component of any effective payer. How you actually manage one of your most high cost driver, which is medication. It's 20 to 30% of your overall expenditure is medication, and the cost of medication is actually not only cost of medicine, but also could drag into the cost of other services that you provide. It's not, once we introduce the IDF as part of the new and essential benefit package, there is a lot of expectation from the market, a lot of expectation from payer and provider, a lot of digital infrastructure need to be put in place, a lot of qualified personnel need to be injected into the payer system to make sure that they realize that saving. And again, it's not only about reduced cost, it's about efficient use of resources. Benefit for patient is to ensure that the prescriber or physician will prescribe most efficient or most efficacious medication that will help him or help her in getting over her or his condition. Payer will ensure that there is an efficient type of dispensing that are happening at the provider side with a proper education at all level of the ecosystem. Again, it's not about reducing cost, it's about efficient use of resources. Again, you can get from here to the door, you can use your legs, you can use a scooter, you can use a bicycle, or you can park a Ferrari and walk by the door. So you can get from an A to B by 3 different ways. So appropriate choice that is most effective in that type of setting is how IDF will be operated, or how we will translate IDF into the market. So it's not about the new kid in the market or the new medication in the market that is more luxurious or had a fancy look. But again, it's what are the most effective route that we need to get into to get to the next level.
Anything we introduce, especially with medication, can't be without risk. What are the potential risks for the IDF, and what we are doing to mitigate these risks?
So I think the major risk is, I think it's change, how we manage change, especially from beneficiary and also from providers. So patient had the luxury of having access to whatever medication they think or his provider think is appropriate, not looking into the entire ecosystem and see exactly what are the best for the system. So the most challenging piece, I think, is change management for both parties or all parties within the system. And the second challenge is having the enough resources in place to implement at the provider side and also at the payer side. But again, it's not rocket science. Something that is established in many countries. US, Europe, most of the developed countries have pharmacy benefit management in place. So learning from others how you can start gradually implementing such an initiative. And again, we are not talking about formulary by itself. We are talking about restructuring access to medicine So challenge in resources and challenge in change management.
Excellent. Any question or if the mic. Introduce yourself, please.
السلام عليكم. أنا فهد التميمي. I'm a family physician and the medical director of تعاونية. I have a comment on Dr. Shabab's question about how can we move faster, and I'll utilize Dr. Rana talk about the family medicine. I think what CCHI doing is great. They did an amazing job in plenty of projects. For example, NAFIS, IDF, the guidelines, the accreditations of providers, accreditations of payers. I think you are moving fast and avoid the speed violation, Dr. Shabab. But my advice is we need to emphasize more on two items. One is patient education, which will engage our patients in what we are doing. And this is very important. It will encourage people to go to primary care, to utilize what we are doing now, because without engaging patients, we will not succeed. And the other point is having more manpower to execute these nice plans. Mainly the family physicians, nurses, case managers. We are in a big short of this, and if we look to numbers of training centers outcome, there is a huge shortage in number of family physicians, and as Dr. Rana said, 70 to 90% of healthcare services done in primary care, and pyramid is upside down. So to put that to the right direction, we need to have at least 50% of the training outcome in family medicine, nurses, and this level of primary care, rather than going to specialized centers or subspecialties, which we can have help from other countries or send patients outside, those 10%. But the majority of our patients, to have a long-term saving and improving quality, we need to focus on training of people who will work in primary care centers and execute these nice plans. And thank you so much.
Thank you very much. So Dr. Fahad is raising the issue of training, which is building the capacity. We got a very excellent question from the online, from the Zoom. We've been talking about the different enablers and for the population health and the transformation, and we did not mention anything about telehealth or telemedicine. What's the potential role or challenges of the telehealth, telemedicine on this journey? Anyone can take it from the panel. Nasser, go ahead.
I was telling Hussein he has the best mic in the, in the room, and Dr. Hassan too. So thank you for bringing this question, because when I answered the question about primary care, afterwards I was like, oh, I didn't mention telehealth. So if you remember when I talked about primary care, we talked about the most cost-effective way of delivering care. Telehealth has a huge potential in the market due to the fact that it can provide in a very low cost. You need technology and high-speed internet and etc. But it's nothing compared to trying to build buildings and managing people and staff and HR and etc. So it has a huge potential. Actually, in fact, in our primary care strategy, we had virtual care as one of the components to provide care. So we're introducing telehealth through primary care, but also insurance companies or any other provider can still provide care through telehealth. So monitoring patients, doing follow-ups, connecting with patients, and most importantly, sharing data with patients. I had patients, I practice in the private practice, in the private sector, and I have patients who I know I just need to follow up on their blood pressure. So they have my WhatsApp number, which is a number that I have just for my clinic. And I told them, you don't need to come back for a follow-up. It's traffic, you're going to need to find parking, you're going to block a slot for other patients who can actually use that slot. Just send me your readings through WhatsApp and I'll try to manage them. This is not the best way to manage patient privacy or manage, patients through WhatsApp, but this is the cheapest technology we have. It doesn't cost me much, it doesn't cost the patient much, but of course we're going to see the market evolve into more applications that are connected with primary care. We know some providers now in the market, they have patient portals. I'm sure Nafis will provide even more information, because one very important thing for telehealth, it's not a Zoom meeting. Telehealth, some people think, oh, telehealth, I can see the patient can see me and we can hear each other. It's not a Zoom meeting, it's not a Teams meeting. More importantly is that I can get to patient's data and the patient can get to their information from me. When I prescribe them a medication, they can see what I prescribe, they can know how they can pick it up, which pharmacy. If they get lab results, they can see it, I can comment on it, I can tell them when the follow-up is, when next appointment is. Yes, there is a huge value in connecting face-to-face, but it has to come with the rest of the. So huge potential, there is a lot of investment. I'm very happy that we have the population health management strategy and the primary care strategy. I think this will give a very strong signal to the market to start investing and moving toward telehealth, because that's where we are going. And our payment mechanisms are going to be geared toward controlling costs. So people will automatically switch to low-cost healthcare delivery methods.
Thank you very much, Dr. Lamar. Go ahead.
Just wanted to add one thing. We've learned a lot about the importance and the patient acceptability of telehealth through the COVID experience, and we've learned this in every country. And what we've learned is that patients don't mind telehealth if they understand it, and actually it's a convenience, as Dr. Nasser said. But the key to driving it to all health, and we learned this in the US system, is parity in payment. That is, if payers will pay the same amount to providers for a telehealth visit that they would for an inpatient visit or in-house visit and clinic visit, then it greases the wheels for everything to work. So provider reluctance is that, well, if I do telehealth, I'm only going to get 40% of that payment, whereas if folks come through my door, I can get the 100% of payment. So payment parity is really a key driver, a key carrot, if you will, to moving to telehealth.
Thank you very much. We're coming to the end of the seminar. Before I conclude, I want the panelists, if there is one message that you want to, either a stepping stone in your opinion to help us accelerate, or a risk that you want to make sure that we watch for, what it would be. I'll start with you, Hussein.
It's the right one. One key message from my experience, my 5th national transformation, is perseverance. It's a long journey, but we need to persevere, and I think Saudi is doing great. He's really persevering. It's the 6th year, and we see results coming up, so perseverance.
Perseverance.
Yes.
Nasser?
Yeah, so the message I want to send is we have Vision 2030 and we have identified goals and we are moving toward Vision 2030, and that's why these projects are there. I highly encourage people to hop on the train as early as possible to get engaged in CCHI. We welcome any feedback. We are very open, and we wanna, and this seminar is actually part of our engagement strategy. And we want to engage with you. We want to engage with everyone. Please engage with us. Hop on the train early. Let's work together toward a vision that's for the whole country, for our next generation.
I think that in a lot of our discussions, we were talking about so many challenges, and I really don't want us to, maybe give the impression that we're distributing negativity or anything. But for that, I'm saying my message is don't be overwhelmed, really, and don't be discouraged, because for every one of the challenges that we mentioned, there is a solution. So, for example, everybody mentioned data problems, lack of data, lack of integrated data. You can start from somewhere and try to, build over time. But whatever you start with, it's going to give you some kind of perspective. We've talked about change management. Change management is a very important thing. Engage the community, engage your people, get them on board from the beginning. The people who are if you're talking about a provider or an organization, get your people involved in the transformation process. Listen to their suggestions. Let them have initiatives for changing and for meeting the vision or your goals in this transformation journey. I think capabilities as well. Invest in your capabilities. Make this an opportunity for you to identify where your weaknesses are. So don't be overwhelmed. You can find a solution, and be patient, like Dr. Hussein said.
Thank you. I think they've touched on the main concerns or the main message. I think two things, again, I'd reiterate. As a public health authority team member, I think we see massive efforts done in different sectors, whether it's the private, the public, the different agencies among the MOH and other sectors. I think coordination, alignment, and collaboration is key. Because in some instances there's massive efforts but not necessarily coordinated, so I think that's a big area we can invest in so we do not reinvent the wheel. Some work has already been done. Number two, I will emphasize again the data part. Always question where is the data, what is the data telling us? I think we need to always be data driven when we're talking about public health, maybe, and population health. Maybe not now, maybe we don't have all the data we need to make evidence-based decisions based on the Saudi population. But I think we need to strive as we go forward that this should be one of our main goals, that when we create strategies, when we create, and when we implement them, interventions, they have to be based on the Saudi population and not just derived from the international community. Thank you.
Thank you.
I just need to, the message that I'd like to send at the end of this panel is that the main focus, or why we are doing this entire exercise transformation, is actually patient-centric. It's a beneficiary/patient-centric. So whatever we do, it's not about cost reduction, it's not about improving quality, it's not about improving access alone, it's all serving patient. So anything we do is a patient-centric, anything we plan to do is a beneficiary-centric. Make sure that we focus our attention on what are the ultimate goal and the ultimate result to improve patient life or patient outcome or beneficiary life and beneficiary outcome.
Thank you.
So my message is actually look at the previous messages. All of them are important. And I've been thinking
No cheating, we need something in you.
every time I think about a message, somebody jumps up and say it, which is, I think, very clever and very smart from all panelists, to summarize everything that we said in very short messages. What I would like to just say, the last words: education, education, education. We really need to educate our healthcare providers on the importance of prevention, on the importance of early intervention, on the importance of value-based healthcare, and also educate our patients about everything that we are doing for the purpose of improving their care, educate our payers, educate our providers and everybody. I think education is a must. Everybody has to take this responsibility on his or her shoulder. Part of who we are working in this healthcare ecosystem, we educate each other, we educate our patients. So never stop on educating patients and other healthcare providers on the importance of everything that we talked about: population health, primary health care, and value-based healthcare, because I think getting that message loud and clear to everybody is of utmost importance.
Thank you very much. Dr. Rana?
I think it's very safe to say that as Saudis, none of us in our lifetime had witnessed a time for change when the signal for change in healthcare is so loud and clear, and it's coming from the highest level of central government to the regulators, to all providers, to even patients. I think if we don't, and we will inshallah, if we don't capitalize on the once in a generation opportunity that we have for change, for really fixing our healthcare system, not only for this generation, but for generations to come, and that the people that will thank us will be 2, 3, 4 generations from now, if we do it right, and inshallah we will.
Thank you very much. Dr. Hassan?
I totally agree. I think we have the skills, knowledge, and experience, and the enablers, and a great opportunity for a pilot. I don't think we should be missing it. I think we should go for a pilot as soon as possible, test, get the results, and spread out.
Thank you.
I agree with everything that's been said. I mean, I'm last, so I got to be creative here. So I'll say this. I'll introduce a concept that we say in the States all the time. That is the Witham principle. The Witham principle. What's in it for me? And so this is a cultural change. Cultural changes and shifts are hard, but to get people moving, you have to show them what's in it for them. And so as mentioned, the beneficiary needs to see what's in it for them, the payer, the provider, our private sector partners, and ultimately the kingdom. So if we can couch everything and frame everything in a way that's what's in it for them, I think that will accelerate the change that Dr. Shabab is leading us towards.
Thank you very much. Before I give it to Dr. Shabab to conclude, just a few announcements. Thank you very much for the great audience on the Zoom. Please share with us the word of wisdom that you want the rest to hear. We'll post them on the CCHY website, and also we'll address all your questions that we were not able to share through the website. So look for that in a couple of days, inshallah, we'll share it with you. There is a survey. Please take 1 minute, 2 minutes to fill it in. Help us do it better next time. And now, Dr. Shabab, if you would like to conclude.
First of all, I'd like to thank our distinguished guests. First of all, let me thank our distinguished guests that I learned a lot from them. I'm really energized with your energy and your hopes and wishes, and I'm sure with this opportunity we'll be able to make the change required. And I agree 100% with Dr. Rana when she said this is one lifetime opportunity. I think it cannot be orchestrated better than this. Our central government are really pushing for transformation. They are giving all the supports to us, and they are giving the guidance. A lot of programs will synergize with our programs. Just example, there is a national program for digital transformation. Don't you think this will help us? Definitely. الملف الصحي, it's السجل الصحي الموحد. It's electronic health record. It's easy to implement as solution. It's off the shelf. You can bring it and put it in. However, the challenge was really to have everybody at the same speed. That's why digitalization and the National Digital Transformation Program will synergize with our program and other programs. So that being said, I'd like also to thank our distinguished audience. Your contribution, your questions has helped us to understand your expectation. Please don't hesitate to share all of your thoughts. We are looking forward to hear from you and to continue our dialogue. This is maybe the kickoff. I'm sure Dr. Hadi and Dr. Nasser and our team members will continue to engage us in those dialogues. And last but not least, I'd like to thank Dr. Nada Al-Aqil, Rakan, Thnayan, Saleh. I don't like to forget anybody from our team who arranged this from behind the scene, and also the organizing company, and also thanks to Abu Yusuf and to our leadership team. Thank you very much.
الله يعطيكم العافية. في ليش؟
يعطيكم العافية جميعا على حضوركم، واستمتعنا بالحوار الثري بالمعلومات، وإن شاء الله يصير له value in improving our healthcare. الصلاة على اليسار، والغداء welcome it's on the first floor في مطعم الموزايك. أهلا فيكم.
يعطيكم العافية. شكرا لكم. Thank you. الله يعطيك العافية.